tumors as such are abnormal growth of cells. And if they are around and in the spine itself, they're called spinal tumors. Now, tumors can be divided in many ways. As you mentioned earlier, they may be benign. That means they are not cancerous, or malignant, which are cancerous tumors. Or they could be defined or classified or divided on how they involve the spinal structures. The spine is a complex unit, if I can say that. It is made up of bone and it is made up of nerve tissue. Now, tumors which involve the bone or the neural tissue, the neural tissue may be the spinal cord, the coverings of the spinal cord, or the spinal nerves themselves. The commonest tumors in the spine are usually cancers which come from elsewhere. They can be from the lungs, the prostate, the breast, the thyroid, kidneys, or they can be blood or what we call hematological tumors, which sort of metastasize to the bony marrow of the vertebrae. Now, in the adult skeleton, the most largest cumulative collection of marrow in a mature skeleton is in the vertebrae, and hence the vertebrae itself is a target for metastatic tumors. The other tumors which are from the bone itself are infrequent but not rare. The next type of tumors, which I mentioned earlier, are from the neural or the nerve structures. That means the nerves themselves, the spinal cord, the meninges or the coverings of the spinal cord, or the supportive cells within the neural confines. Now, this division of tumors can be divided into which are outside the covering, which is the dura, or within it. Now, outside the coverings we have described are bony tumors or mets. Inside the coverings, what we call are intradural, that is inside the covering of the dura or the spine meninges. Now, they can be again divided into what we call outside the confines of the spinal cord, but within the dura, or which these are known as intradural extramedullary tumors. And those which come from the spinal cord itself, which are the intramedullary tumors. Now, these tumors are usually slow growing and they evolve over a period of time, and hence the symptoms are insidious. Now, as the tumors are very varied, so is the presentation. The metastatic tumors can present just as back pain. Now, back pain on a background of a history of cancer is a red flag. And that means that these people have to have urgent scans. Now, fortunately, most of such patients are already under the oncologist or the cancer specialist. Therefore, when back pain arises on a history of metastatic or tumors, they have immediate scans. And if these metastatic tumors are causing compression to the spinal cord, they can give weakness down the legs or even the hands, and in instances called paralysis, and also loss of bladder and bowel function. As compared to this, the nerve tumors, which are slow growing, the symptoms can vary from irritation of the nerve, which can result in sensory symptoms down to pain down a leg, or it could even result in compromise of the limb function. Now, pressure on the spinal cord itself can result in what we medically call myelopathy. What happens here is these people can start getting indifferent sensations down the arms and legs. Their fine motor skills are reduced. Their coordination may be altered, and hence they can have difficulty in walking. Like spinal tumors, the prognosis and the treatment is very varied. The malignant tumors themselves are governed by the extent of the disease itself. The objective of spinal tumor surgery in such metastatic tumors is to preserve neurological and bladder function. The prognosis, of course, depends on the extent of the tumor, the adjuvant therapy, that is radiotherapy and chemotherapy combined. So the prognosis is basically how the systemic disease is controlled. Now, coming on to primary bone tumors, intradural extramedullary tumors, the objective is to remove the tumor as totally as possible whilst preserving neurological function. Now, that is the surgical challenge. Now, that is where the skill of the surgeon and the adjuvant modalities like microscope, various image-guided facilities come into function. The results, if the surgery is done well, is the prognosis is excellent, the patient leads a normal life, and the recurrence rates in such tumors is very low. Intramedullary tumors, now these are the tumors which are within the spinal cord itself. Their prognosis, unfortunately, is not very good because they compromise the structural integrity of the spinal cord itself. And the surgical options are limited to reducing the size of the tumor within the cord, that is debulking, and then followed up by adjuvant therapy, which usually is radiotherapy. And of course, the radiation to the tumor may affect the normal functionality of the spinal cord itself. The surgery, again, it's very varied. The surgery for benign tumor is to remove the tumor completely. And in a malignant tumor is to reduce the bulk as much as possible. And of course, if we change the structural integrity of the spine itself, that is the bony part of the spine, then you have to stabilize the spine. The surgery usually involves approaching the spinal tumor without disturbing the anatomical structure of the spinal cord, and then strutting the spinal skeletal in such a way as to provide stable bony structure. Now, what I mean by that is if the location of the tumor is at the front of the spinal cord, then you approach it from the front or anterior. And if it is behind the spinal cord, then of course you approach it from the back. Once you have done so, if you think you've compromised the structure of the spine, that is the bony spine, then of course you need to put in screws and rods or even cages to stabilize the structure so that the stability of the spine itself is not compromised. If the tumor does extend into the adjoining structures, which may be the neck, it may be the thorax or the abdomen, then of course a multidisciplinary or a multi-surgical team approach is used, and that is what I would do in my practice. Of course, it depends on what the tumor is. The pathology of the tumor will tell you what the life expectancy is and when it is picked up. Malignant tumors, if they're picked up early, the prognosis, of course, is good. But if they're picked up late, then the objective of the spinal surgery in metastatic disease is to preserve function. Whereas in benign tumors, that is the non-cancerous, non-malignant ones, whether they are from the bone or from the neural tissue, the prognosis is excellent as long as the surgery removes the tumor as complete as possible. And fortunately, as I mentioned earlier, the recurrence rates are low. Intramedullary tumors, unfortunately, the prognosis is not very good, both in terms of the quality of life and also mortality.